So good afternoon. We are KCJ Consulting, and we are here today to discuss how we can improve the healthcare needs of the Sioux Tribe members of the Lakota people. I'm here with my colleague Carolina. She is the community specialist. We're here with Jordan. He is the financial expert, and my name is Karen, and I'm the health systems specialist. So the agenda for the day, we're going to provide a recap of our presented assignment, our recommendation. We're going to use Doris's story as a springboard to explain the prevalent issues with the Native American population. We will discuss our intervention HEAL, and then we will end with our costs and savings of our intervention. So we were given the task of involving local and regional institutions in order to provide enhanced process of care for Native American people. So the way that we started tackling this was we believe we should engage the tribe members, we should identify the community needs, create systematic partnerships, and this will bring forth a positive healthcare impacts. So our recommendation is HEAL. We like to call it. It is known as Health Systems Empowering Aiding Leaders. We project this will generate $8 million in net present value savings. Before we discuss the breakdown of our intervention, we'd like to explain how we got to it. The quadruple aim guided our intervention. To start off with, we have quality, population health, which is the accessibility of health care, cost, the affordability of health care, and provider satisfaction was just added by the Institute for Healthcare Improvement as the fourth part of quadruple aim. Before it was known as the triple aim. And this all leads to improved process of care. We would like to focus on the quality component of quadruple aim. And the Institute of Medicine defined quality care as safe, timely, effective, equitable, efficient, and patient-centered. If any of these components are not addressed, it is not considered quality care. So as presented in the case, Doris feels as though there's nothing she can do to change what happened anyways. So the current health systems in place have failed her. She feels helpless in her current situation. And we would like to introduce our intervention to change this for Doris and other people like her in the Native American population. So Doris is a 23-year-old female. She's a Sioux Tribe member of the Lakota people. She has experienced significant trauma, both personal and historical. And there is a lack of social support, such as her friends, her family, and also in terms of her clinical providers. This has all led to chronic anxiety, a discontinuous health experience, and poor oral health. So the current systems in place have left her helpless, which may be the case for other Native American populations. The Native American people experience 2 times the national average of mental health conditions and oral health conditions. Moreover, there is 85% unemployment rate, specifically in the Pine Ridge Reservation. So this root cause analysis particularly focuses on Doris's case. However, her case is a springboard for many other Native American people. This may include long wait times, understaffed clinics, a cultural disconnect between provider and patients, and moreover, there is a historical trauma, distress in Western medicine, and adverse childhood events. This all leads to a lack of quality of care. So we'd like to introduce our intervention, which is HEAL. To start off with, I will cover health systems. So in Doris's case, it seemed as though when she communicated with her traditional healer, she felt much more comfortable, whereas when she was connecting with her clinical provider in the hospital. So how is it that we can allow for a patient such as Doris to communicate with her traditional healer, if she so chooses, and her clinical provider? We suggest implementing telehealth. And specifically, we would like to partner with Avera Clinic, which currently serves nationwide to about 790,000 patients. And we believe by building on their existing infrastructure, this will be a very successful intervention. These are some of the areas in South Dakota Avera Clinic currently serves. As you can see, there is right here from the laser. In the Pine Ridge Reservation, they are currently not serving that area, and we believe that it'll be beneficial to bring them in order to increase the cultural fluency between providers and patients using the traditional healer. And it's important to note that Avera Clinic has seen $170 million in total health care savings. So again, it's a video conferencing system, and it will be used during patient consultations if the patient so decides to do so. And we believe that this will help open the line of communication between the providers and the patients. We foresee a decrease in ED visits, readmission rates, and physician burnout and fatigue. This will address the quadruple aim of quality and provider satisfaction. We believe that this will be so because currently providers experience they may feel low morale when they are with their consultations with Native Americans, just because they're unsure of how to best deal with their needs. And we believe that introducing telehealth will allow the traditional healer to connect the physicians and the patient in order to increase their cultural fluency and ultimately increase health outcomes. Now we will move on to empowering, which I will pass along to my colleague Carolina.
Thank you, Karen. Again, my name is Carolina, and I'm the community specialist, and I'm going to touch on the last three components of HEAL, starting with empowering. So empowering individuals is extremely important to help them feel like they have autonomy and ownership of their health. So ultimately, that's what we want to do. And we want to do that in two ways. First, with community-based participatory research, or CBPR, and community health workers. Now, the really important thing about community-based participatory research is that it involves the community members from the beginning of the planning through the implementation and then through the end and getting that feedback. And we want to know how we can improve the overall health experience of the Sioux Tribe members, and the best way to find out that information is by asking them. And with the goals being that we'll improve their health experience and get that culturally sensitive, patient-centered care, because we want to get that feedback from here and use it in the telehealth so that we make sure that we're doing the best for the Sioux Tribe members. And then for the community health workers, the Indian Health Services already has community health representatives, so we want to capitalize on that, make sure they're going into more urban areas, help them so that they can assist when there's a little bit of cultural disconnect between patient and provider, and to help with leadership development, which we'll talk about in a little bit. So how does it work? Currently, the Oseti Wakan Foundation is an organization that's been trying to build a wellness center on the Pine Ridge Reservation, so we want to help them get that started. And the wellness center will really be the hub and kind of the basis of where all of this will be going on. Since this is community-based participatory research, the needs are going to be defined by the community. That's what we want to know. We want them to tell us. And the impacts, again, will be defined by the community. We want to definitely build capacity so that when this community-based participatory research is over, the community will still continue to have positive outcomes. And of course, we want to empower them, feel like they have ownership of their health, and be encouraged to interact with the health system. And this touches on the quad aim of quality and population health. We can also apply the social cognitive model to the community-based participatory research because it says that people learn by observing others, and that consists of three factors: personal factors, behavioral factors, and environment. So with this CBPR, we really want to create an environment in which people are encouraged to engage with the health system, encouraged to improve their health, and ultimately engage in those positive behaviors. The next aspect of HEAL is aiding. And that consists of something we like to call dental days, which is really a partnership between schools, elementary, middle, and high school, and dental professionals to help students get the care that they need. So that consists of a collaboration with Circle of Smiles of Delta Dental of South Dakota, which is an organization that currently goes on the Pine Ridge Reservation and administers dental care to children ages 0 to 9, pregnant women, and people with diabetes. So what we want to do is bring in students in the dental professions and really give Circle of Smiles that manpower to get as many children as they can through fluoride varnishings. And a fluoride varnish is a very simple, non-invasive procedure. It's essentially putting a fluoride paste on the teeth. And we've seen, the research shows that fluoride is very helpful in reducing tooth decay. So we hope that doing this will reduce the number of cavities among children and reduce the days of school missed, since one of the main reasons kids do miss school is because of dental complications. And this touches on the quad aim of population health and cost. And then the final component of HEAL is leaders. Now we want to build leaders in the future. We want to empower the students. And we can apply the health belief model to what we like to call the health academy. Now the health belief model is that we have these modifying factors that we can't really change. And they affect an individual's perception of a situation, what barriers they feel like they have to overcome, the threats that they have. But if we give them certain cues to action, they might be empowered to engage in a certain behavior. In this case, the cues to action we want to give is resources so that the students will be more inclined to pursue the health professions. So the way Health Academy works is that it would be an after-school program with enrichment activities such as tutoring, volunteer opportunities, guest speakers in the health professionals and in the health professions, and help with college applications. And we hope that the impact will be increased high school graduation rates, since currently it's very low. We want to increase college acceptances, and we want to increase the number of healthcare professionals that are Native American. Unfortunately, the Native Americans are underrepresented in the health professions. For example, only about 0.5% of physicians are of Native American descent, so we definitely want to increase those numbers. And then finally, this is just a little map kind of showing how these things all play together. So as I mentioned, the Wellness Center is kind of the hub, the basis of where all this is. It's where the HEAL coordinator would be. The Avera Clinic in the Wellness Center is where we would have that technology set up for the traditional healers to connect with people in the clinic. And again, the HEAL coordinator would be using that to interact with the schools for the Health Academy, building those relationships, and with the schools for the dental days as well. And then finally, our ultimate goal. At the beginning of the presentation, we gave a quote from Doris where she said she felt like nothing was going to change. She felt pretty helpless, and we don't want her to feel that way. Now, in this scenario, at the end of her interaction with the traditional healer, she said she felt more centered and encouraged than she had in a long time. So we want her and individuals like her to feel that way when they interact with the health system, not just with the traditional healers. So that's really our goal. And again, one more time, our intervention is called HEAL, and it consists of health systems, empowering, aiding, and leaders. As far as how we're going to evaluate our program, we've decided to use a CDC program evaluation. So we're going to engage our stakeholders, the tribe members, health professionals. HEAL, we've just walked through that. Evaluation, we're going to be using process and outcomes evaluation throughout this to make sure that the things we're doing are working, and if they're not, what can we modify to make sure that they are? Evidence, the things we are suggesting are evidence-based. Impacts, we've kind of talked about that as we've talked about HEAL. And finally, the lessons learned. So we hope to learn a lot from this, and to, again, build that capacity so that when we leave, that we still see success among the Sioux tribe members. And finally, our future outlook. So this is just a few examples of things we hope to see. Our intervention is a 10-year period. So if we're looking at now, comparing to what we want to see in 2017, we want to decrease unnecessary ED usage by about 33% among Pine Ridge residents. We want to decrease cavities in children by about 35%. And we want to increase high school graduation rates by about 10%. And now I'm going to pass it on to our financial expert, Jordan, who's going to show us how much this is going to cost, and most importantly, how much we're going to save from it.
Thanks. So really quick, how much is all this going to cost, right? Because there's a pretty big intervention, covers a lot of different areas. And so what I'm going to do is cover the timeline first, look at the overall cost, and the savings to the overall system. So there's a lot going on right here on this slide. This is the timeline. What I really want to bring your attention to is the Wellness Center. So in the first 2 years, the community-based participatory research is going to take about 2 years. And the reason that takes 2 years is we want to make sure that we're very targeted, very specific on what we're doing, and make sure that we're really addressing the needs of the people, so that the following 8 years will show a lot of significant success. Another part I want to bring your attention to is the evaluation and financial analysis portions. Under the evaluation, we want to run this in 2 separate phases. So about 5 years for the first portion of running a full HEAL intervention. So that's the telehealth, the empowering period with the Wellness Center, the dental days, as well as the Health Academy, and addressing those outcomes after the first 5 years, and then doing a second intervention and measuring the outcomes as well in year 10. And what we expect is that in that second portion, in the second 5 years, is when we're going to see the significant amount of savings, breaking even in year 6 from all the costs that were spent on developing all these programs. So looking at the first part of what we're going to do, we look at an expected cost of about $4.6 million in present value. So that's saying spending money in the first year and all throughout the 10 years, if we would take all that money and discount it back at a specific interest rate, that money would cost about $4.6 million today. We expect an overall savings of about $8 million in net present value. And what that number is indicating is that after all the money has been spent, after we've significantly spent money on all the programs, there'll be a net savings of about $8 million, which we expect to be reinvested into a lot of the programs of the Indian Health Service and all the different projects that Native American people might need. So looking at telehealth, a lot of the costs that are going to be associated with telehealth are regarding the consultation and contracting with the Avera Clinic. So currently the average cost of an emergency department visit is about $560. Through telehealth and through teleconferencing, the average consultation cost is about $140. So just by implementing telehealth and the technology available through the Avera Clinic, we expect a significant cost reduction in what patients are going to be having to spend. And so with that, about $477,000 in costs to the system. On the savings side, again, as I mentioned, decreased emergency usage as well as decreased readmission rates leads to an overall net present value of about $6 million. And again, assuming that we're helping 61,000 patients, which represents half of the people who rely on all the healthcare facilities in the Great Plains area, like in South Dakota, Minnesota, Iowa, and Nebraska. Onto the Wellness Center, this is the empowering phase of our intervention. A lot of the costs are going to be associated with just the materials and the staffing for community-based participatory research, the salaries for the community health workers who are, again, recruited from the community, the mental health counselor, and absorbing that cost of the Aseti Wakan Wellness Center, which is about $2 million. And we expect the cost of about $2 million in present value. On the savings side, the result of community health worker intervention leads to unnecessary ED usage, decreased ER to hospitalization rate, and length of stay, which we expect will be an overall net present value savings of $3.7 million. Onto the dental day side, the overall costs for the program are going to be a result of the volunteer coordinator salary, the different resources and materials needed to go into the schools and provide the fluoride varnishings, and assuming that 4,000 patients are helped, should be about a cost of $842,000. And on the savings side, decreased ED usage and overall cost of the system for dental cavities should yield about a little under $2 million in savings over the course of our 10-year intervention. And onto the Health Academy, the main costs, again, are community health worker salary, program coordinator, and the materials. And with 500 students being helped, that's assuming for the 10 years, every year, there'll be an increase in 50 students per year that are graduating from Pine Ridge Reservation Public Schools. That's an overall cost of about $518,000. And on the savings side, what we really wanted to measure was a decreased cost to the system in terms of welfare programs, as well as an increased overall earning potential from students who were not graduating before to who are graduating and pursuing advanced degrees, leading to an overall savings of about $1.8 million in savings. And so again, a review of the financial impact, assuming about 2% inflation and a break even in the sixth fiscal year, and an overall cost outlay of $4.6 million, we expect an overall net present value savings of $8 million, which is significant because it represents 1% of the current Indian Health Service budget. And again, that's why that's important, is because that money can be reinvested into the Indian Health Service projects that are going on to help increase overall health outcomes. And another really significant number from our intervention is the internal rate of return of 30%. So what that's saying is for every single dollar we're spending on the HEAL program, there'll be a net return on investment of $1.30. And considering that the current stock market is about 8% internal rate of return, this is a really significant and productive outcome of our HEAL intervention that we expect will lead to overall enhanced health outcomes. And so in conclusion, HEAL intervention that comprises these four components leads to an overall net present value of $8 million and will lead to an enhanced process of care for Native Americans like Doris, especially because she's felt helpless. And so to the Indian Health Service, to the CDC, and all of the stakeholders involved, we as KCJ Consulting want to put the onus back on you all to take all of the components of our intervention and implement them as you see fit for enhanced process of care. So we thank you so much for your time, and we'll open it up for any questions.
Well, that was very good. That was outstanding. Really enjoyed it. A couple of questions. You said early on that Avera saves $170 million. Is that per year? What is that related to?
Since 2009, based on the contracts that they've had with other areas, rural, urban areas, that's the cost that they've saved since 2009 by implementing telehealth.
By implementing telehealth. So telehealth savings for them was $170
Correct.
million. And is Avera an urgent or critical care clinic, or to take? You said instead of having the ED, they'll do telehealth to Avera. Now, Avera is urgent care, critical care.
So they cover tons of different things. I mean, they're involved in assessing whether or not though they have the technology will be implemented in an urban area or a rural area, and they'll determine whether or not somebody actually needs to come to the ER. They have on-site responders who will go to the area and actually measure whether or not how severe the disease is, and provide very basic primary level of care. So I mean, the technology is really what we're after, to make sure that the people on the reservation are actually, we're assessing whether or not, do they really need to come to the ER? Do they really need to stay? Because, and a lot of the times, the ERs in the Great Plains area are about 2-month wait times a lot of the time. So by having that technology, we expect to decrease the need for them to even have to travel all the way to an emergency room clinic.
Thank you.
Very, very nice job, and I was so glad you started with engaging the tribes. And so in your processes, you did this initiative for us and bringing it to us. Did you have any Native American consultants or conversations as you put together this plan for us?
No, we did not.
So I had a question about environment. And your definition of environment. I'm just curious about, in the case that identified water, unsafe water and water with H. pylori contamination and lack of fluoridation is a key environmental issue. And I was wondering how does the HEAL initiative look at any of those sort of physical environment?
So yeah, when we initially looked at what we wanted to do in terms of the fluoride in the water and a lot of the contamination, we thought that it would be a significant cost burden to apply, especially with limited resources. And so what we really wanted to just, I guess, communicate was, by spending that money, we're actually saving money for the system, versus if we were to spend a significant amount of money trying to, I guess, replace all the infrastructure and all the water filtration systems. It wasn't necessarily it would be a little more sustainable, but it may not be as cost effective in the short term.
Yeah, so right now I guess we're looking for feasibility right now, but the money that we're saving by doing this can then be reinvested to use to fix those kind of infrastructure issues.
Jordan, I was trying to follow the financials a little bit, and you kind of, what I think you did was it went from local, like the cost of the health center on the reservation, to kind of a global savings if you were taking an entire country. Did you go from local to national? Back
No, sorry. It was primarily supposed to be local. The 61,000 patients that I addressed, that was assuming that we're introducing telehealth into the Great Plains area, so the Native American region where Pine Ridge is located, as well as a couple of other reservations that rely on the IHS facilities that are there. We're just assuming that savings to the overall system would be from that area. So it's really
okay, so it was
localized.
Still local.
It was all localized, correct.
And then I do want to know who's doing your investing at 8%. I'm with you.
Any conversation with anybody at Avera? I mean, is this a realistic possibility?
Yeah, so yeah, we reached out to them, and again, we're trying to reach out to people who were Native American in Avera. We tried multiple times to connect with them, and we couldn't, but we took a lot of the information that was located on their website, looked at a lot of the outcomes that they show that they've had in the past, with especially rural areas, and we saw that, I don't know if you saw the map, but we can go back to it in a second, but there were Avera clinics located in everywhere except where the Pine Ridge Reservation is. So, I mean, it doesn't seem like it would be too hard of an issue to actually just connect and build the infrastructure there and connect them.
So nationwide, Avera Clinic actually partners with 235 locations, and specifically we think it could be a great solution for the Pine Ridge Reservation, just because this would be the type of patients that they really look forward to partnering with, because they are right now specifically target rural areas, such as those in South Dakota and Iowa and Minnesota.
So any ideas on why right now, perhaps, why they aren't working with Pine Ridge Reservation? Any ideas?
Avera Clinic in particular, or just?
Avera Clinic in particular.
Yeah, I mean, again, I think a lot of that just comes back to like the lack of resources and the lack of continuity of care. And the Indian Health Service, right now, I mean, they have a lot of budget increases and they're requesting a lot of budget increases. So, I mean, the main thing I can think of is just the lack of resources available.
Right, of the infrastructure, and just because it's new technology, so if we were to present it in the wellness center, we would need to have someone that's available and capable of explaining it to the traditional healers, to the patients, so that they're aware that this is a technology that is usable for them to learn how to use. Even so, when our proposed intervention, if it were to come into reality, were to leave, because we wouldn't want to introduce the technology and it just sits there when the HEAL coordinator leaves, and they just look and they're like, what are we supposed to do with it now?
You mentioned that in an evaluation you would use tools to look at process and outcome. What specific tools might you consider using?
For which portion?
So I think
What process and outcome evaluation tools would you use in looking at the outcomes for the Wellness Center and the
right.
Health Academy and so forth?
Right, so we would use a lot of the PDSA cycles, so a Plan, Do, Study, Act, in order to ensure that everything that we are implementing is being as effective as possible in the community. So, for example, if we target, if we're looking at telehealth, how it affects the burnout rate for physicians, we would use a health-related quality of life and ensure that the track that we have set in motion is working. If it's not, we can backtrack or speak to the engaged stakeholders, ensure that we change it as quickly and efficiently as possible to have the best health outcomes.
So you'd use surveys?
Right, so
For some, yes.
for some of them.
For the physician and on the provider side, a lot of other metrics are just looking at, I mean, the literature talks about the effectiveness of CHW. It was measured by ED usage and decreased ER to hospitalization rate. So a lot of those other standard metrics as well.
Okay. That's what I wanted to get at. Which of the standard metrics do you think you'd use would be most cost effective for you to use? So you answered it. Thank you.